So welcome back to the third part of this antimicrobial in ICU or antibiotic in ICU. We have already finished this pharmacokinetics and the pharmacodynamics. So we will be continuing with the rest of the topic in this lecture, or we will be taking one or two more parts. So before proceeding to the further part of further details of this part, let me thank you all who are watching this video, and it makes me very happy when I get message or comments for the further publications of the subsequent parts of my last two videos. Again, I am saying this is not a lecture, but basically a small attempt to make these things or these complicated things little simple to you, which are very important for the exam purpose. So let not waste the time for in this all this topic and talk. So get into focus the topic of our today's discussion. So where we end is the minimum bactericidal concentration or the minimum inhibitory concentration. So let's start with the minimum inhibitory concentration. It is the minimum concentration of antibiotic required to inhibit the growth of the bacteria. As you can see in the subsequent test tube, and up to the fourth test tube, there is visible growth of bacteria. From the fifth test tube onwards, there is no visible growth. And this is the minimum concentration of antibiotic tested in the laboratory, which is required to inhibit the growth of bacteria. But what I have mentioned previously also, that this inhibition doesn't mean killing of bacteria. What I mean to say, if we subculture this liquid in a media, we will see that there will be growth of bacteria in that subculture or in the media. So the bacteria is inhibited for growth. There is clearance of the media, but the death of the bacteria is not confirmed. So inhibition is MIC. Coming to the bactericidal concentration. Now, if we subculture, see in the previous slide what we are seeing, the clearance of the test tube. From the fourth test tube, there is a clearance, but when you subculture, there is a growth of bacteria. From the fifth, there is also growth. From the sixth, there is no growth. So total clearance in the fifth tube. So the MIC is 2 microgram per ml. It is a minimum concentration where there is a complete inhibition of the growth of the bacteria and complete clearance. But when we talk about subculturing, there is still a growth at 4 microgram per ml. There is a killing or the death of bacteria. So this 4 microgram per ml is known as minimum bactericidal concentration. We have to keep in mind, more closer this MIC and MBC, the more bactericidal is the drug, because we give the drug in our daily to daily practice according to the MIC. So if we are giving drug according to the MIC and the MBC is very clear to MIC, then the bacteria will die with the concentration of drug that is administered. Am I clear? We give drug according to the MIC. So if the MIC and MBCs are very clear, closer, then if we give a drug according to the MIC, then the bacteria will ultimately be killed by that concentration, and that concentration will act as a bactericidal concentration. So MBC by MIC, so MBC by MIC if greater than 4, if the MBC is very far away from MIC, then by giving drug, by considering MIC, we cannot kill the bacteria. So if they are very far, then the drug become bacteriostatic. If they are closer and the ratio is less than 4, then they become bactericidal. Coming to the limitation of MIC, one of the most limitation is the inoculum effect. What do you mean by inoculum effect? Is that normally the MIC is measured in the laboratory, but the concentration at the level of tissue or at the level of infection may be higher than the amount of bacterium inoculum used for the testing. Normally in the testing, it is used 10 to the power 5. So if the concentration of bacteria is 10 to the power 8, 10 to the power 10, If the inoculum is more, then that MIC or the concentration which inhibited the growth in laboratory will not act at the tissue level. So this is basically known as the inoculum effect. Again, the laboratory doesn't consider the albumin level. We all know lesser the albumin level, more will be the free fraction, and easily it will be cleared out. So lesser will be the time of the drug inside the circulation. So it doesn't consider all these factors, whether the patient is on dialysis or ECMO, or the patient is having a normal or low albumin level. These are not considered while measuring MIC. Again, MIC doesn't tell us the mechanism of resistance, which is also a limitation, and we need to find it by the genotyping or Carba-R like test, by which we can assure or get that what is the reason of this resistance, whether it is a carbapenemase or is it a non-carbapenemase production. If carbapenemase, then what are the genes involved? Effect of the additional drug is not considered. We also get a synergy of 1 or 2 antibiotics if we are using together. That is not measured during the measurement of MIC. Again, during the measurement of MIC, there is a twofold dilution. There may be some story happening in between these two folds, which goes on missing during the measurement of MIC. So again, this is a limitation of MIC. And last but not the least, the condition from which the culture has been sent until the report is coming, there is a gap of 24 to 48 hours. There is a lot of change within the body, starting from the pharmacokinetics, dynamics, and lots more. So that also limits the use of MIC. But still today, we use the antibiotic according to this MIC and breakpoint. So coming to the breakpoint, a new term we learned at the last line of the last slide. The breakpoint is basically the wall beyond which the drug become resistant and before which the drug become susceptible. So what I mean by this, so the breakpoint is the highest concentration of the drug that can be easily achieved to define that this drug to be susceptible. Again, I am clearing and breaking this down. We have learned MIC. So MIC, lab said that the MIC is 4 or 8 microgram per ml. That means that bug in that patient will be killed by this X drug at a concentration, well, not killed, will be inhibited but at a concentration of 8 microgram per ml. Clear? But what we give from outside, suppose we give meropenem 1 gram TDS. So by giving that, we can achieve a concentration maximum of 2 microgram per ml. Suppose. So if the bug is inhibited at 8 microgram per ml concentration of meropenem, then the bug will be resistant because we cannot achieve that level within the body. So the breakpoint is the highest plasma concentration of the drug that can be achieved by the standard dosing regimen. So you have to be very clear here that if today I started giving 10 gram TDS meropenem, so I can achieve a very high level of concentration, right? But that will not be physiological. That will affecting kidney, that will affect liver and other organs, right? So we cannot give 10 gram TDS meropenem. If we could do that, then if the MIC would have been 8 also, we would have covered, because 10 gram TDS meropenem, if we give, we will achieve a very high concentration of meropenem in the plasma. But that is not physiological. So what we can give maximum dose by which the maximum plasma level what we can achieve is basically the threshold or the wall or the breakpoint. Below, if the MIC comes below that breakpoint, then it becomes susceptible. If the MIC comes above this breakpoint, then it becomes resistance, because by the standard dosing regimen, we can reach up to this level, maximum level. If the MIC is below this, we can achieve this. But if the MIC is above this, we cannot achieve this. So here become resistant, here become susceptible. So this cross or the border or the wall is breakpoint, and it is fixed for a drug, for a organism. So it is fixed for a drug, for an organism. It is the maximum concentration which can be achieved. But MIC for a patient, for a drug, and for an organism will vary. And if this MIC falls below the breakpoint, drug is susceptible. If it crosses the breakpoint, then it is resistant, because we cannot go beyond that breakpoint, because going beyond that, achieving concentration beyond the breakpoint will affect the organs, will affect the physiology of the body. So these walls or these limits or the thresholds are fixed by the two big bodies, European UCAST and American CLSI, European Committee on Antimicrobial Susceptibility and Testing, and American CLSI or Clinical and Laboratory Standard Institute. So they have fixed this breakpoint according to the highest dose possible. So this is, here comes the concept. So if the patient is having a higher MIC and meropenem come resistant, still we have no option other than meropenem. Then what we say? We say, let's go from 1 gram TDS to 2 gram TDS. That means we are increasing the breakpoint, because what the breakpoint is set with a concentration of 1 gram TDS. So if we increase the dose to 2 gram TDS, then the level which was set by 1 gram TDS increases, goes up. So the MIC now, which was lying between the previous breakpoint and the newly set breakpoint, will now become susceptible, because now that level can easily be achieved. So that is why when we say if the meropenem MIC is less than 8, we can try with a higher dose of meropenem, right? So what we actually are doing with a higher dose of meropenem, we are actually setting the breakpoint one step higher. So the MIC up to 8 can be achieved with that dose regime of 2 gram TDS, which was not possible with 1 gram TDS, is now possible with the dosing regimen 2 gram TDS. We are actually lifting up the breakpoint and making the so-called drug, resistant drug, susceptible only by increasing the dose. So the last point is very important. The breakpoint determination takes into account the antibiotic dose, including the maximum dose for which these values are established. So remember that the breakpoint are established by a certain value. If you come today and say that, sir, I will give 20 gram TDS meropenem and will kill all bacteria, you can kill all bacteria along with also your patient. So breakpoint are set for physiologically possible maximum amount of drug or dose that can be used. We can slightly increase the doses and can achieve a little higher breakpoint, making some MICs coming into the susceptible zone, but not to increase further and killing the bug along with killing the organ of the patients. So this we have studied the breakpoints below which it is susceptible, above which it is resistant. So coming to the breakpoint categories, there are epidemiological breakpoints, PK/PD breakpoints, and the clinical breakpoint, what we get in our daily to daily practice. We will be discussing this PK/PD breakpoints little later using those graphs after we read the time dependent and the concentration dependent antibiotic. We will be coming back to this part, but what we need to remember from this, that ecological, epidemiological or ecological breakpoint, what do we mean? That normally if the patient doesn't have any sort of mutation, then it is called wild type of bacteria. So the wild type of bacteria belongs to one part or one side of the ecological breakpoint, and the acquired resistant bacteria belongs to the other part or other side of the ecological breakpoint. But when it comes to the clinical breakpoint, then it is shifted little forward, because some sort of resistant bacteria are also covered in the clinical breakpoint. What I mean to say, that even the bacteria having small amount of resistance become sensitive to the antibiotics. So here wild type has no resistance. So this is a clear cutoff. This is wild type and this is acquired or mutational resistant. But among the acquired or mutational resistant, some part becomes sensitive. So this line becomes shift from here to here, and this part becomes sensitive. This is intermediate category. We will be coming to the subsequent slide, and this become the resistant category. So starting from here to here means some organism with acute resistance still is susceptible to the antibiotic. So actually clinically the breakpoint line is this, but ecologically or epidemiologically, if we consider that what is the breakpoint, if a slightest of mutation we considered as resistant, then the ecological breakpoint is this. Any further query, you can ask me directly in the comment section. I will be happy to answer you. So let's go forward, otherwise we will not be able to finish the topic. So these are the PK/PD breakpoints from the Monte Carlo stimulation. We will be discussing after we go and discuss the time dependent and the concentration dependent antibiotic. I'm going a little slow because these are the very hard concept to understand. So if we understand this, then we may be finishing the latter topic very fast, and that will really give the utilization of making these videos. So coming to the question, we very often comes to a resistant or a susceptible sheet where we get more than one antibiotic susceptible. Then how to decide which antibiotic to be used or which antibiotic? So for using antibiotic, the first and foremost thing is you need to consider the site of infection. We need to consider the site of infection. Do not use doxycycline in urine, or do not use TG-cycline for blood. So these are the areas we need to avoid, and means what I mean to say, do not use lipophilic drugs for blood and hydrophilic drug for tissues. So we are well read and we are well conversed with this thing. So first goes the source. Then comes the PK/PD, other effects using of ECMO, CRRT, creatinine clearance. And after that also you are left with 2 or 3 options of using these drugs. I have blah, blah, blah. Nowadays it is very rare. We have 1 or 2 options, and that also goes by the source of infection. We get echinocandin for urine, other all resistant. So nowadays scenario is worse, and it will be more worse in the subsequent days if we don't use our knowledge in selecting antibiotic. So if we get more than one antibiotic susceptible, then we come to a term known as efficacy ratio, which how it is defined? It is defined by the breakpoint, which has already been set by the UCAST and CLSI. We cannot change that, only not if we change the dose of the antibiotic or maximum dose of the antibiotic. We cannot change the breakpoint. The breakpoint are set for certain maximum dose of antibiotic by the observed MIC. So if we divide, this is known as efficacy ratio, and the drug with an highest efficacy ratio will be selected for giving to the patients, considering the site of infection, PK/PD. After all, considering all, if we have the luxury of 1 or 2 drugs in our hand, then we can go for this efficacy ratio and we can choose the proper antibiotic. Coming to the MIC creep, we have seen in certain situation we get a colistin or polymyxin B intermediate. we start using colistin, polymyxin. We repeat a culture on the 5th day or 6th day, thinking that now the cultures will come negative. But unfortunately, what happens? That Klebsiella returns with a resistance to colistin. That means the MIC of colistin, which was below 2 or equal to 2, has crept up to 4 or 8 or 16, making the colistin resistant, and this is known as MIC creep. It was previously described in Staphylococcus aureus with the use of vancomycin, but fortunately or unfortunately, it is not bound to this vancomycin or Staphylococcus aureus is valid for almost all antibiotics in the critical care unit, and you will get to see this, that we are getting sensitive bugs. After using, the bugs are smart enough to form a coat, and you can also identify clinically that there is no improvement, the amount of improvement what you were expecting. So there will be a therapeutic failure, there will be a clinical cure failure, and there will be, sorry, and there will be a slower clinical response and ultimately a higher relapse rate. So we have to know that the MIC creep is the subsequent increase of organism MIC over time with the use of the drug, resulting in this therapeutic failure, increased morbidity, lower clinical response, and higher relapse rate. Coming to the method of testing antimicrobial or the antimicrobial susceptibility testing, there are phenotypic method, there are molecular based method, and which are the most modern nowadays are the mass spectrometry or multi-top mass spectrometry method. So coming to our conventional method, dilution, diffusion, gradient testing, and the automatic testing. So these are the conventional method, and we have to keep in mind that nowadays the laboratory, most of the laboratory, if not few, also you are using this diffusion disc. The most of the laboratory is using Vitek 2, and which is an automated device. So you have to keep in mind that the microbiologist goes by, and this is the reason why they can give the result very early with these automated machines. But nowadays, even in some government hospital setups, there are use of the diffusion disc. So we will be discussing one by one before going into these molecular methods or mass spectrometry. We'll not be discussing this in details. We will be discussing this molecular method while we discuss the resistance pattern in the subsequent part of these lectures. And today we will be focusing in these phenotypic methods. So coming to the Dix method, an antibiotic is placed and there is a zone of clearance around this antibiotic pellets, means as the antibiotic diffuses, there is so here what we do, we put an antibiotic pellet inside of the disc and we measure the clearance, the amount of bacteria growth which is cleared off. More it's clear, more is the susceptibility, which is reverse of the MIC. In MIC, it's more the MIC, it become resistant, but in case of bacterial or in case of antibiotic disc, more is the clearance or more is the diameter of clearance, more is the susceptibility, less is the clearance, and more is the resistant bug. So we can see that around this B, though the antibiotics are different, so there is a less zone of clearance and there is a big zone of clearance or zone of inhibition, what we say, because the bacterial growth is inhibited in this area. So this antibiotic C covering this diameter gives an idea that whether this drug is sensitive or resistant. As like breakpoint, we also have a cutoff for this zone of Dick's diameter, and this make the antibiotic resistant or susceptible. Coming to this famous D test, we need to remember this D test for Staphylococcus aureus or Streptococcus pneumoniae, or specifically if we say methicillin resistant Staphylococcus aureus, and this D test comes into play interaction between the erythromycin and clindamycin. So the concept should be very clear. What we mean by this D test, the it is very, very simple. Just listen to the lines, what I am saying, that see, clindamycin is clearing up. So this green you imagine as a culture media, right? So where there is a growth of the bacteria. So clindamycin is clearing up the growth of the bacteria, and this clindamycin for this Staphylococcus aureus is sensitive because it has cleared a zone of inhibition, and we consider this as a sensitive. It is greater than the cutoff, so it is sensitive. But you see, there is no clearance around the erythromycin. So erythromycin is straightforward resistant to this bug Staphylococcus aureus, right? So this is, both are acting independently. Erythromycin is resistant, clindamycin is sensitive. Don't go by this negative positive test. We will be coming to this, right? Now what is happening below? Clindamycin was clearing. Suddenly something happened here. So if we imagine this picture, what we see that clindamycin was diffusing in these directions and was clearing this culture, right? Erythromycin was also diffusing in this direction and was not able to clear the culture, but by diffusing somewhat in the clindamycin zone also, it has not affected the activity of clindamycin. Clear? But in this category, when it was going or penetrating to the zone of clindamycin, erythromycin was when penetrating to the zone of clindamycin, then what it does that in this zone of bacteria is induces the resistance to clindamycin. So erythromycin induces the resistance to clindamycin in this part where there is a strong overlap. This is the area marked 1. So the clearance of clindamycin, which is sensitive, which was supposed to be a full circle, is terminated in a shape of D, right? Because the erythromycin has diffused to this area, and by diffusing to this area, it has inhibited the action of clindamycin by inducing resistance of clindamycin to that bacteria. So basically, D test in one line test the inducible resistance of clindamycin by erythromycin, right? Clear? The D test, if come positive, if it has a, so first when we will test D test, if E is sensitive, C is sensitive, no necessary of D test. Erythromycin is sensitive, clindamycin is sensitive. अपना अपना खुश है अपना अपना दुनिया पे. Problem comes, erythromycin is resistant, clindamycin is sensitive. If the culture report gives like this, erythromycin is resistant, no question of using erythromycin. Question comes, will we use clindamycin? Yes or no? Then the answer is we have to do a D test. Now you will ask me, sir, if I am not using erythromycin, then why to fear of inducing resistance of clindamycin to this bacteria? If I am not using erythromycin, there is no question of induction of resistance. So no fear. The answer is no. Even if you are not using erythromycin, there are certain factors if the bacteria is bearing that gene of inducible resistance to clindamycin, there are certain factors which can be induced even if the erythromycin is not used. Erythromycin using is just a in vitro test done in the laboratory, but even if the erythromycin or any sort of group of drug of macrolides are not used, then also this inducible gene can be induced and give a resistance to clindamycin by certain other factors other than the erythromycin. So very clear, D-test tests the inducible resistance of clindamycin to Staphylococcus aureus or else in Streptococcus pneumoniae. Remember, this test is also important for Streptococcus pneumoniae, right? And uh, and if it is positive, then not to use clindamycin. If it is negative, then it's to use clindamycin. When to go for test? If erythromycin is resistant and clindamycin is sensitive. If erythromycin is sensitive, clindamycin sensitive, no issues. Erythromycin resistance, clindamycin resistance, no question, clindamycin not to be used. Erythromycin is resistant, but clindamycin is sensitive, then only you have to go for D-test before you use clindamycin, or else avoid clindamycin, use some other antitoxin property drug like linezolid or something else as per the sensitivity. So this is agar dilution. We do the same antibiotic broth test by diluting the concentration of the antibiotic. But what we most commonly do is the broth dilution method testing, and we dilute the subsequent antibiotic in the broth, and we have already read the minimum inhibition concentration is the MIC and the minimum bactericidal concentration is the MBC. So this is the very frequently used broth dilution method, or the most commonly used in nowadays. But nowadays we don't do the broth dilution directly. We do it in some automated method, that is Vitek 2, which we will be coming in the subsequent slide. This is for your exam. It may come as a MCQ or in also in OSCE. This is the E-test where a strip is placed within the antibiotic culture media, and there is an increased gradient or increased concentration of antibiotic subsequently, and the point from where this eclipse starts to form is the point where the inhibition starts to form, and the minimum concentration of antibiotic which inhibits this growth we know is the MIC. So the lowest MIC, this is 0.5, this is not 5, this is 0.5. So this is the MIC is where the ellipse or this ellipse intersect with the strip. This is the minimum amount of antibiotic which actually starts inhibiting the growth of this bacteria, and this 0.5 forms the MIC for this drug. So this is known as E-test or E-strip, as we say. So we are very much familiar with this Vitek 2 system. I will advise you all to visit your microbiology lab if you are doing DRNBs or DM, or if not also you are preparing, then also if you have scope, please visit your microbiology lab, or else see some videos in the YouTube, because it is very difficult to explain this here, but I will try to explain what exactly happened in the Vitek system. In the Vitek system, there is actually different curds for the gram negative, for the gram positive, for the spore forming bacilli, for the yeast, for the other Neisseria haemophilus group of bacteria, and also for the anaerobic bacteria. There are 6 types of curds. So what they do, they first grow the culture. So it is very important. Automated machines, they will give you the result, but after the growth comes. So once the lab inform you that there is a growth of GNB or GPC, that means that there is a growth in the culture media, and they through the microscope has come to know the GNB or GPC. You can ask them about the biochemical testing, like we ask lactose fermenting or non-lactose fermenting, but you expect a result of a turnaround time of around 12 to 20 hours after this report comes ki GNB or GPC is there. So this is something little bit separate for blood culture starts not directly with this plate isolation. It starts with a backtake. It gives a signal, backtake is positive or negative. Then we go for the growth, and then subsequently for the Vitek system. So blood culture needs some time, but whereas this sputum or urine culture, they are inoculated directly into the dishes, and once they grow, they are subcultured, and then they are diluted according to the optical densities, and they are transferred after this dilution according to the optical densities. As you see, there are 6 different curves and there are 6 different optical densities. They are checked in the density check meter, and once this dilution is made, how these dilutions are made? They are made with an sterile saline along with the culture. They take some inoculum from the cultures, isolate from the cultures, they mix in the tube along with the sterile saline, and they check the optical density diameter, and after that they dip the cord into this tube, and these bacteria by certain mechanism goes into this card, travels through this pipe, this blue pipe, and travels into this card, and then they are placed into the system where this turbidity measured for the color development or turbidity, and by their set database they are compared, and then they are tagged resistant or sensitive. So first, culturing, subculturing, dilating, checking the optical density, putting the card inside the tube, the cultures goes into the well. So what is in the card? In the card there are wells where there is an increasing amount of antibiotic. Actually, what we do in the broth dilution test or broth microdilution test, there this is the simple thing that is done here, where we have wells. Once the bacteria goes imbibe, it goes into all the wells, and in the wells there are certain antibiotic with increasing concentration in the row and column. So different antibiotics with different concentration, and the concentration at which the turbidity or the clearance matches with the set database, and likewise it is given resistant or sensitive, right? So this is the method. You go visit your microbiology lab and you get a better idea regarding this test. So coming to this advantage and disadvantage, so you take the screenshot and read this. What's Dix diffusion is easy, but the problem is the Dix diffusion doesn't give you an MIC value, where the broth dilution give you a MIC value. These automated systems are good, but relatively expensive and need expertise, and that and is not available in certain government institutes or certain small labs. Multi-top MS give you a very early report, but the problem is they do not give you the MIC value. So the selection of antibiotic becomes very difficult. So these are the advantage and disadvantage of different methods. So go by them one by one. It may come in your exam. So I am not discussing this in details. So coming to the CLSI UCAST, the CLSI has given the direction to use this broth and agar dilution, but we do by the automated system now. Though the automated system is a modified broth dilution testing, but CLSI has said broth and agar dilution. But for fosfomycin, they have recommended agar dilution, wherein for colistin and daptomycin, only and only broth dilution. Right, so it is very important. Colistin is by broth dilution, but we do by automatic method. So sometimes which is coming susceptible or intermediate may come resistance in the broth dilution. We will be discussing that why colistin is always given I, right? So UCAST comes to the broth microdilution. The UCAST suggests to have a broth microdilution. They are against this agar dilution, but for fosfomycin and mesalamine, they recommend for agar dilution. So you have to remember fosfomycin is suggested to do in a agar dilution plate. So you will see that in certain antibiotic we do not get in the Vitex system or in the broth dilution, though phosphomycins are reported, but they put DICs separately. So even if we don't have this chart or the updated Vitex system, the antibiotic can be tested separately by the DICS test. But for the phosphomycin, agar dilution is suggested to be the method of choice of testing, but nowadays we do the almost all of the testing through this automated Vitek 2 system. What you can see in the YouTube, you can see these videos and you can get a very clear idea what I have said regarding the Vitek 2. So we will be starting with the susceptible and resistant in the coming part. We are going very slow, so we will be uploading this part, and then susceptible resistant, we may within 1 or 2 days, we will be going through this part very soon.